Hi, this is Brian Kim. I want to share with you this case of a patient who had a ruptured globe injury. If you look at my past videos in the library, you'll see that there was a ruptured globe where a patient had complete loss of his iris tissue, as well as a dislocated single piece acrylic lens, hyphema, vitreous hemorrhage. And so I cleaned that up, took the lens out, did a pars plana vitrectomy, and this patient's now healed many months after surgery, eagerly awaiting his secondary IOL. After I do the Yamane technique, my modified technique with the Sensor AR40 lens, he will undergo the Human Optics artificial iris implantation surgery. As you can see, this is the patient. Very little iris tissue. It just exploded and disintegrated out of the eye after the injury. And you can see this is really a beautiful illustration of the Yamane technique in this case with my modification. I use a 27 gauge cannula with the tip inked, and I ink the limbus on the right side with the ink pen, and then finding 180 degrees on the other side, marking the limbus as well. Again, using Weck-Cel sponges are of paramount importance because you need to have a dry surface to get those distinct marks. This is a fixed caliper from Epsilon. I indent 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent using the other end of that fixed caliper. By indenting the sclera, I can use that 27 gauge cannula to ink those indentations. Again, indenting the sclera on the left side in similar fashion, 2.5 millimeters posterior to the limbus and then 2 millimeters adjacent, and then using that 27 gauge cannula, inking the tip and then marking the conjunctival surface. Remember, this technique only works if the conjunctiva reflects the intended scleral needle placement, and so the conjunctiva needs to be immobilized and fixed during the scleral needle placement. This is a contralateral limbal incision to help me externalize the leading haptic. Again, this patient had thorough vitrectomy, so I should not have to do a vitrectomy with this case. I'm making an incision on the left side here so I can inject some viscoelastic. Obviously, since there's no iris, most likely the viscoelastic is going to fall in the back, but I'm just giving it a try anyways. Holding the incision with a cannula, and this is the 3 millimeter blade. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. Now I've put a lot of bubbles in the eye, and I will remove those bubbles before I proceed with the surgery. I decided to move that incision for the AC maintainer, so I made another incision. And then as I'm doing the maneuvers, I said, maybe I should move it on the other side. And so remember, the AC maintainer is supposed to help you, not hurt you. And sometimes it can get in the way. And just know that you can move it wherever you need to keep it out of your way. This is a 25 gauge needle. I'm going to bend it fairly close to the tip, making sure I bend it in such a way that the bevel is going to face the right. And I mount it on a 1 cc syringe full of BSS. This is the right side needle. Again, I'm going to bend about 9 millimeters from the tip, and it's mounted on BSS in similar fashion. Bending the needle, again, 9 millimeters from the tip, making sure that the bevel faces the main incision. And this is the left side needle, again, 1 cc syringe full of BSS, and I'm going to bend it at the hub with the bevel facing the contralateral limbal incision. And here is the cartridge for the AR40 lens. I'm pushing cohesive viscoelastic through the barrel and on the platform. This is the Sensor AR40 lens, making sure the optic is seated within the cartridge, bringing the wings together, making sure the optic bends backward, making sure the leading haptic comes out straight through the barrel and the trailing haptic comes out through the back. Sliding the cartridge into the injector, making sure the trailing haptic is up and away from the barrel so that it can slide the plunger without hitting the haptic and damaging the haptic. Advancing the lens, and I'm ready to go. This is a 25 gauge needle. I'm going to slide it through the contralateral limbal incision. The needle bevel is facing to the right and the IOL injector bevel is facing to the left. Both of them are facing each other. My assistant advances the lens. As the haptic comes out, I make sure it's docked on the bevel of the needle. As the lens is delivered, I'm able to pull the needle out and the haptic's already out. Again, passive docking technique. Delivering the lens, making sure the optic comes out flat and the trailing haptic is facing to the right. I activate infusion. You can see beautiful anatomy, gives you a really good view of what I'm going to try to do with the surgery. Turn infusion off and then pushing dispersive viscoelastic to coat the corneal endothelium and to push the lens back. You want to make sure, again, the optic is underneath the AC maintainer. holding the eye with forceps, stabbing the conjunctiva and sclera at the first mark, flattening out. You saw that maneuver, flattening out. Turn on infusion now, tunnel, tunnel, tunnel. Go to the second mark, dive down towards the optic nerve. And that's my technique. You want to turn on infusion when you're tunneling the needle through the sclera, which will ensure proper technique and execution of that needle through the sclera. This is the smooth microforceps. Again, I'm pulling the leading haptic out more, pushing the optic away, which gives me a lot more room to maneuver the trailing haptic. I'm going to slide the trailing haptic into the incision. I'm not bending it or breaking it or doing anything really harsh to the haptic. Very gentle here, very gentle. And then I'm going to dock the haptic on the bevel of the needle and then flattening it out. 2 pushes is all you need, and that's it. Disengaging the needle from the syringe, laying the needle down. In this case, I'm not going to internalize the leading haptic. Why? Because there's no iris. So I'm holding the AC maintainer with the forceps, which is essentially contralateral counterfixation. I'm stabbing the first mark through the conjunctiva and sclera. I'm flattening out. I'm tunneling to the second mark, and then I'm diving towards the optic nerve. Rotate the needle into view. And this is a really nice technique because, again, with the Yamane technique, you have to lay that leading haptic into the angle over the iris, and in this case, there is no iris. And so in this way, I'm able to secure that leading haptic for this modified Yamane technique. Another advantage as to why I do the technique this way. So then I'm grabbing the leading haptic, carefully internalizing the haptic into the eye. I want to get close to the tip as possible. That's why you see me just inching towards the tip. And then once I'm in, dock the haptic on the bevel needle, re-grab, dock it one more time, a couple of pushes, and then I'm in. Withdraw both needles out, pulling the left side needle further out, grasping the haptic as the needle is withdrawn, limiting how much haptic comes out of the eye. Drying the surface of the eye in the area of the haptic first. Cauterizing the tip of the haptic to create a small bulb. You can see the haptic is laying flat, which is what you want. This means you have good scleral support for the lens, which will best simulate capsular bag placement of the lens. I'm trying to withdraw the right side needle. You can see there's some tension on the contralateral optic haptic junction. Clearly this patient has a big eye. In these cases, these patients have a larger white to white. I'm having some trouble with the cautery. Finally, I'm able to initiate. But again, you can see nice and flat. The haptic is sitting nice and flat. Nice scleral support. I do not have a flagpole sign, which means I have excellent scleral support for the lens, which will best simulate an in-the-bag IOL placement. Pushing the haptics flush to the sclera, reapproximating the conjunctiva. Go ahead and place a 10-0 nylon suture through the main incision. So again, you can see really good lens placement, nice scleral shelf. Again, no flagpole sign in this case. You saw the execution of my modified Yamane technique using the AR40 sensor lens. I'm able to externalize the leading haptic through the contralateral limbal incision using a 25 gauge passive docking technique. This gives me much better access to the trailing haptic because I can push the optic away. I have a much easier time threading that trailing haptic into the right side needle. Because there is no iris, I can't really put this leading haptic into the angle on top of an iris because there is no iris. And so you saw after I placed the left side scleral needle, I was able to directly pull that leading haptic into the eye and then docking it on the left side needle and then threading it in, cauterize the tips. This patient's post-op 1 month visual acuity was 20/25 uncorrected. His manifest refraction was a -3/4 +1 with 20/20 vision. So this patient had an excellent refractive result. His other eye actually has very good refractive result as well, the eye that does not have a dislocated lens. He's extremely happy with his visual result, and he's really excited to get the artificial iris at a subsequent surgery. So I hope this was helpful to you, and I thank you for your attention.